Good evening, everybody. We're waiting for a few more people to arrive, but thank you so much for everybody that's come in this evening and given up your spare time. For you guys who don't know me, I'm Phil. I'm the regional sales manager for Haag-Streit Surgical. I cover the Midlands, and I'm the product manager for the iTrack and the iTrack Advance MIG system. With me, I have my colleague Kevin and Martin, who are the other regional sales managers. So hopefully you guys know them. We are very blessed to be. We're very blessed for Dr Mary Qiu to give us her time this evening from the Cole Eye Institute in Cleveland, who will be hosting our evening of who to select and what to expect. So without further ado, I will pass over to Mary.
Hi, everyone. I'm Mary Qiu. I'm currently a glaucoma specialist at Cleveland Clinic, Cole Eye Institute. I did my glaucoma fellowship training here about 6 years ago, and then I used the iTrack original 250A product during my fellowship training, and I really liked it. And so then I was in practice at the University of Chicago in Chicago, Illinois for the last 5 years. And there is when the iTrack Advance came out. And so I was really excited to try that out, and I used it in my practice in Chicago. And now I've been asked back to Cleveland Clinic this past summer. So I kind of came back to where I trained. And now I'm the associate program director for the Glaucoma Fellowship. There's 6 of us here, and we are all doing cases with the iTrack Original and the iTrack Advance. So I'm really excited to share with you guys some information about iTrack and iTrack Advance and show some cases, mostly from my experience in Chicago and a recent video from my new job here in Cleveland. I was also able to meet some of you guys at the UKEGS meeting in Southampton earlier this fall. So it's really exciting to get to talk a little bit more with all of you guys in the UK. All right, so we are all glaucoma specialists. We all know that traditional glaucoma surgeries aim to shunt the fluid from the anterior chamber to new drainage pathways in the subconjunctival space, like with trabs and tubes. We're all probably pretty familiar with angle surgery as a concept, and angle surgeries, angle-based MIGs, they all aim to increase the aqueous outflow out the conventional outflow pathway. So from the anterior chamber through TM into Schlemms and out the collector channels to the episcleral venous system. There are obviously MIGs with implants like Hydrus and iStent, where the goal is to bypass the TM and stent open Schlemm's canal, or other MIGs products that cut or excise diseased TM, like a KDB type of dual blade cutting instruments. Canaloplasty is special because it treats both the proximal and distal outflow system and offers the option to not cut into the TM, which is a little bit less destructive. So canaloplasty, the goal is to use viscoelastic to distend Schlemm's and flush everything kind of downstream. So canaloplasty enhances the physiologic outflow pathway, so trabecular meshwork, Schlemm's, and collector channels. It is not trying to route the fluid to some other non-physiologic place, such as with trabs or tubes. And it's not going to go to the suprachoroidal space either, such as with mini-ject. The goal is to keep everything as physiologic as possible so that you don't have any danger with hypotony, because of course anything in the angle, assuming you don't have a complication, the pressure should not drop below episcleral venous pressure. So you have a lot of good safety there. So in eyes with glaucoma, there can be resistance at all these levels, the TM, Schlemm's canal, and the downstream collector channels. And so canaloplasty pumps a lot of viscoelastic through this whole system and increases outflow at all of these kind of pinch points where the resistance is. So the goal is that there's both like a mechanical and a physiologic way that the canaloplasty can work to help relieve obstructions. And so the goal of the iTrack and the iTrack Advance is that you want to catheterize Schlemm's canal. You take this catheter, which is clear plastic, it goes into Schlemm's, it reaches all the way 360 around the entire thing. It's not only 180, it's all 360. And then you can viscodilate. So it delivers viscoelastic in a pressurized way that you can control how much viscoelastic is going in, and you can deliver quite a lot of it. And then as you see in this picture, there is a blinking light at the tip of the catheter. So you will always be able to see where the tip of the catheter is as you're performing these procedures, so that there is no danger that the tip of the instrument is landing somewhere else that you don't want it to go. So catheterizing Schlemm's canal for 360 degrees is helpful because the physical catheter will break through any adhesions that are inside the canal. It'll break through any tethers from the juxtacanalicular tissue to the back of Schlemm's. And sometimes there can be herniations of the TM that gets sort of sucked into the collector channel orifices. And so by catheterizing it and then viscodilating, we're sort of poofing everything back open so that it can flow patently. And then the viscodilation, the pressurized viscodilation is important because we're dilating Schlemm's, dilating the distal outflow system, and even stretching the TM and creating some focal disruptions within TM that may help the aqueous get through the TM a little bit better, even without overtly tearing it or cutting it or excising it. And again, this is pressurized viscodilation, which is different than, another product like Omni, which delivers a much lower volume of visco, so it's not quite so pressurized. So here is a picture of the iTrack Advance handpiece. It is currently the only illuminated canaloplasty device that has the blinking light on the tip, and it is designed for a high volume of pressurized viscodilation and 360-degree catheterization of Schlemm's canal all in one go. You don't have to flip it around and do half and then do the other half. It's all in one 360. So here's another zoomed in picture of the handpiece. You can see that the very tip of the cannula it's made out of metal, and it's where the catheter comes out, and then you see the blinking light on the tip of the catheter. The cannula has a spatulated tip, and so you can very easily lay it onto where the TM is, and it lays nice and ergonomically and flat on the TM. And then when you push the actuator, that blue flat slider, when you push it forward, the catheter comes out of the cannula tip, and just with one push of a finger, the catheter comes out for 360 degrees. And the nozzle can be swiveled in any direction that you want. And so it doesn't have to only face forwards or backwards. You can sort of swivel it a little bit. So in case it's more comfortable to hold the handpiece with the actuator and the nozzle like 45 degrees apart, because sometimes that can be a more comfortable way to hold your hand, you can sort of customize which way the nozzle is pointing so that you're holding the handpiece as comfortably as possible. And you can also flip it around so that you can go the other direction if you hit an obstruction and you need to flip it around or something. And I want to highlight that this actuator, it's very low profile, it's very flat, and it's kind of shaped like a ski. And so you can put your finger on the top of it, and if you just push it all the way from the back to the front, apparently the gear ratio in this thing is 2 to 1. So for every millimeter that you move the actuator forward, the catheter comes out 2 millimeters. And so the catheter comes all the way around with a very small movement of your finger. This is great because you don't have to pick up your finger and go like this. If you can see my screen, you don't have to pick up your finger and slide it forward multiple times. You just lift up your finger once and you put it on the slider and you push it forward just once, and the catheter goes all the way around in one go. And so this is a great design for the little mechanism that your finger is touching, because this minimizes the amount of jiggling that the device is doing as you're sliding it forward. There's very minimal jiggling because your finger just moves once, compared to something like the Omni. You have to pick up your finger and roll the wheel multiple times, which can be difficult to keep the thing still if you're having to move your finger so much. So here you can see a zoomed in picture of the catheter as it comes out of the cannula tip. And this is emphasizing that the helon that's connected to this, you can deliver about 100 microliters of this viscoelastic. And when you click the little dispenser, there's like a little here, the little clicker. Every time you turn the spinny thing at the end, or your nurse or assistant turns it, it delivers 2 to 3 microliters of viscoelastic. So if you click it about 40 times, this gives you about 100 microliters of viscoelastic as you come all the way around. What's great about the iTrack Advance is that the delivery of the viscoelastic is completely controllable by when you want it. So you can click as you insert the catheter, you can click as you withdraw the catheter, you can click as you hit an obstruction and you're trying to blow through some obstructions in Schlemm's so that you can continue to advance the catheter. You can deliver less of it if there's an area that you think is a little bit suspicious for some reason and you don't want to, do too much right there. And so this is great because the other types of canaloplasty devices out there, or like the Omni, for example, you don't get to control when the visco is getting delivered. It's only delivered as you withdraw the suture catheter. But in this one with the iTrack Advance, it's completely customizable when and how much viscoelastic you can deliver. So I actually like to deliver viscoelastic on the way in as well as on the way out, but other people like to deliver viscoelastic only on the way out. And there's pros and cons to each of those, and I can talk about a little bit of that later, but I just want to highlight that this is just completely customizable when you choose to click the thing. And so that's a feature about it that I really like. And so here's just another zoomed in picture of the tip of the cannula. You can see it's sort of spatulated at the tip, and it's kind of a rounded shape where the catheter comes out of it. And then you can see the viscoelastic coming out of the tip of the catheter, and you can see the blinking light at the very tip of the catheter. The catheter is coated with like a special material so that it's very slippery when it's wet, and so it glides into the Schlemm's canal and slides forward very easily. And if it is not sliding forward, you can then choose to deliver some viscoelastic, and then that will help lubricate Schlemm's and help the catheter slide forward very easily. The tip of the cannula is it's sharp enough that you can use it to incise the TM and get the catheter in. So you do not have to use a separate blade or a separate instrument to make a little hole in the TM so that the catheter can go in. Most surgeons just use the tip of the catheter itself to get that started. Sometimes I like to use a different instrument to get it started when I'm teaching my trainees, because maybe they're not an expert yet, or they're not comfortable using the tip of the cannula to make that hole. So in some of my videos, you'll see that I have already made the hole with a different blade, but you don't have to do that. The actual injector is the right amount of sharpness to make that incision to get started without traumatizing any tissues nearby. Okay, any questions or comments up to this point? I'll just pause for a minute before I go into the next two slides. Any thoughts or comments or questions so far?
Mary, can I ask you a question? You said you can flip your catheter if you have an obstruction. So I had one case, so it would not just, there was an obstruction, so it won't advance, it won't proceed. So I came back and then I tried. Then I have never had to flip my hand because you have an Omni, you do it regular, but with this, slightly different. And when you flip, that your thumb, you go to, I found it tricky, so I tried to flip, but I struggled.
I didn't quite understand the question. Can you say that again?
So you said you can also flip and you can go from the other side.
Oh yeah. Mm-hmm.
And so I've had one because with Omni you do it regular. With Omni it's a backhand. They call it backhand. But with this, I once had to do it and I really struggled. And the other thing is the way you hold the device, you have to use your thumb, won't you? Because you flip it now, unless you're using your left hand, which I'm not a left-hander. So you do, when you flip it, you have to use your...
Yeah, I understand what you're saying.
Can you show us? Can you show us how would you hold it if you were to flip it?
Yeah. So basically, the difference between the iTrack Advance and the Omni is that the Omni can go in through the temporal main wound. So the paracentesis or the main wound, it would be directly temporal. With the iTrack Advance, the shape or the curvature of the tip of the cannula is a little bit different than the shape of the Omni. So it's actually recommended that you make an extra paracentesis off to the side. So if you're right-handed, there's an extra paracentesis like a couple clock hours away from your main wound, similar to where a hydrous incision would be. Right. So for that, you have to put it in that para, and that's for going forehand. If you have to flip it and go backhand, then you have to make another paracentesis on the other side, the mirror image. Otherwise, if you just flip it and keep the same paracentesis, the angle of approach to the TM will not be correct. It will be too acute. It'll be too steep. And so then the catheter is not going to want to go in Schlemm the other direction. So when I flip it to go the other way, I will either just try to go in through my phaco wound and just go as far left as I can, or I will go in through my para that's on the other side, or sometimes just make another para. I am also not left-handed, I'm right-handed, and I'm also not super comfortable holding things with my left hand like a MIGS device. One thing that I've noticed that I can do is actually just hold it with my right hand and just reach across my body and hold it here, and that has been fine. Sometimes I will just use a hands-free prism so that I don't have to hold my own prism. put it down, and then both my hands are free. So I'm holding it with my left hand, but my right hand is really actually stabilizing it. So I feel that I can use both hands because I'm working on my non-dominant side and I'm not as comfortable. So sometimes I switch to a hands-free prism. You don't really have to switch to a hands-free prism. You can still hold your normal prism, and you can even just hold it with your right hand and go in from a little bit on the side, and that works as well.
Thank you. Thank you. I think, I would probably try the few more tips because I didn't make a separate wound when I tried to flip. So that's one mistake. And the other thing is, I think you could potentially stabilize your left hand, as you said.
Yeah.
And then you can use it. The only thing is, I don't know, you can use, and then you have to use your left index finger to do it, right? I mean, I was trying to use my right hand
finger. Yeah, I'm not using my thumb.
Yeah,
and the beauty of it is you can make the nozzle point in any direction. So I just flip the nozzle around so it's the other way, and then I'm still holding it with my left index finger, but I'm stabilizing it with my right hand because that's more comfortable for me. But you can just use a hands-free prism or whatever in that case.
Thank you.
Yeah. Okay. Any other comments so far from anyone else, or I'll just move on to the next topic? Okay, I'll go on. I don't see anybody pausing, so I will go back to my slides. Okay, so then the next thing I want to talk about is which viscoelastic do I use and in what situation? So you are viscodilating Schlemm's canal, so you need to have some viscoelastic that is going into the lumen of the catheter because that's what's going to perform your viscodilation and the canaloplasty part. I always use Helon for that. Helon, regular Helon. I guess it's called Helon Pro, but not Helon GV, not Helon 5, not Viscoat, not something dispersive. Apparently ProVisc is okay, but I just always use Helon. That's the one I've always used. And no matter if I'm doing this combined with phaco or standalone, pseudophakic or phakic, I will always put Helon in the lumen of the catheter itself. So now the other question is, what do you put in the anterior chamber as your viscoelastic? It kind of depends if you're doing this before or after phaco. So when you're doing this procedure combined with phaco, I always do my MIGS before the phaco. That's just my personal preference. I do that because I'm always teaching residents. And if I do the MIGS before the phaco, the cornea is clear. There is no edema at the wound. Whereas if I do it after phaco, if the resident has been phacoing, like maybe the cornea is not so clear. So I just, like the stability and the view of doing it before the phaco. And when I combine it with phaco, I actually use Helon 5, which is a little bit extra. It's like a little bit aggressive. You don't have to use a very, very heavy viscoelastic like that. I like it because when I was a fellow here, I learned my MIGS that way. And Helon 5 is so heavy that it tamponades any reflux bleeding. It tamponades so that the AC doesn't get any striae in your cornea. If you're trainee or first learning MIGS and you're pushing down on the cornea with your prism, you just don't get any striae because the Helon 5 is so heavy. And if you're first learning and you're kind of accidentally burping on the wound, Helon 5 will not burp out of the main wound, so you don't have to keep refilling it. Your chamber will not shallow. It's just more of a training wheels for my residents. I think in a more real world setting, once you're comfortable with the basics of MIGS, you should be able to do this under Viscoat or Helon or ProVisc or really anything in the anterior chamber. But just know that I like to use Helon 5 kind of mostly for teaching purposes, but it does make for an extremely clear view with absolutely no striae and absolutely no reflux heme, which I think is a great feature because if you have a bad view and you have a lot of blood, it's going to discourage you from wanting to do more MIGS. So when combined with phaco, Helon 5 in the anterior chamber for me and Helon in the catheter for me. So now if I'm doing it standalone in a pseudophakic eye, oh, yes.
Mary, can we interrupt for a question a second? Rajan Taylor would like to ask something. Rajan, can I pass over to you?
Hi, Mary. Hi, Rajan Taylor. We met in UKEGS.
Hello.
Hi. Just a quick question. What gonio lens do you use?
The regular Swan-Jacobs one with the stick that comes off of it. I use the left-handed stick, but I think the one where the stick comes off in the middle might actually be better for this because it'll allow a bit more flexibility if you need to go the other direction, because that way both the right and left hand could hold the stick equally comfortably. I use the one where the stick is on the left, so if I have to switch and go backhand, it's a little bit awkward to hold it like wrap my hand around. And then for my hands-free prism, I use the Katina hands-free prism, the one that has a little notch at the top where you can grab it with the 0.12, and that one's actually pretty broad for the view. And I can send out a link later of which prism I use if I switch to the hands-free. I have not had a chance to try the Gonio Ready, the hands-free prism that hangs off the microscope. It kind of looks pretty cool. And so I think for other sort of double-handed maneuvers in the angle, it might be cool to try one of those hands-free prisms, but I have not had experience with that one.
Brilliant, thank you. And just another point, I use Helon 5 for MIGS as well. But if you're doing it, do you do your phaco straight after with Helon 5 in the AC?
I add, so right after I do the MIGS, I have Helon 5 in the AC. I do my Rexus under Helon 5. And then before I start, and then I burp out some Helon 5.
Yeah.
And then I hydrodissect under Helon 5. And then before I start phacoing, I put a shell of Viscoat.
Okay, brilliant.
So I do,
it's just, yeah, I just found doing a Rexus under Helon 5 is quite a different experience to doing it under normal Helon. It behaves very differently.
Absolutely a very important point here. My very first phaco as a fellow here at Cole, I was under Helon 5 for the MIGS, and then my attending said, watch out, the Rexus feels a little different, watch out. And I didn't really know what that meant, and it means that the Rexus will run small. Helon 5 is extremely heavy. So if you pull with all your normal vectors, like you're making a Rexus, your Rexus will run tiny. So if you're making a Rexus with Helon 5 in the AC, you have to pull your vectors so that you're exaggerating how big you make it. And you also have to re-grab more often because the Helon 5 is so heavy and sludgy, like you're working under molasses. So that is an important adjustment that you have to make if you're making the Rexus under the Helon 5. So I've made that adjustment. So basically, like every phaco MIGS, I'm under Helon 5, and I'm used to just making my Rexus with like totally different vectors. So when I teach the residents, I say, don't do this if you're under Viscoat, because then your Rexus will be a totally different size. And then other people have asked me, how do you get the Helon 5 out? And I just make the point that by the time your phaco is done, all the Helon 5 has left through your IA. So there would not be any retained Helon 5 in the eye at the end of the case. Whereas if you're doing this after phaco, if you wanted to use Helon 5, you do have to IA really thoroughly just to make sure all the Helon 5 is gone, because you do not want any retained Helon 5 in your anterior chamber. But when doing it pre-phaco, it's always gone by the end.
Thank you.
Thanks. Okay. And so when I am doing it standalone in a pseudophakic eye, I put Helon in the catheter and Helon in the anterior chamber. So in this case, the reason for that is because I'm only going to make a para, and I'm not going to have a main wound, and I'm not going to open the IA. And so with just Helon in the anterior chamber, you can actually rinse most of it out with VSS on a cannula. So you don't have to use real irrigation hooked up to the phaco machine to evacuate the Helon that's in the anterior chamber. And this does give you more striae on your cornea, and it does give you a little bit more risk of reflux bleeding. If you depressurize the anterior chamber a little bit, with the Helon will not hold back the blood as well as Helon 5. And so sometimes even with a pseudophakic eye, if it's a little bit dicey for whatever reason, like maybe there's a little PAS or just something a little bit shady, a little bit suspicious going on, and I'm just worried, like maybe if I'm under a PK or under a DSEC or DMEC, anything that's a little bit higher risk, and I'm worried about the view, you know, I will just open the Helon 5, and then I will tell them to open the bimanual IA, and then I will just plan to use the bimanual IA to evacuate the Helon 5 at the end. So just know that the Helon 5, you cannot rinse it out of a para with BSS on a cannula, but it is a lifesaver if you need your view to be perfect. And so along those lines, if I'm doing standalone in a phakic eye, like a young person who has uveitic glaucoma or steroid response glaucoma, and they have a totally clear lens and they're like 25 years old, my mentor just does Helon, and I'm a chicken and I just use Helon 5 because I just don't want to risk the lens coming up at me or dinging the lens or something. And so I've been calling upon the Helon 5 in the phakic eyes that are too young to get a cataract, and doing my angle procedure with my perfect view. And then I just open the bimanual IA to rinse out the Helon 5. And sometimes if I'm, you know, if I'm ending up performing some goniotomy or trabeculotomy with that procedure, which is not on label for that use in the UK, but if I am performing some goniotomy with that procedure too, sometimes when I rinse out the Helon 5, I will then replace it with Helon when I come out with my irrigation, and then I will slowly irrigate out the helon with BSS on the cannula. So chamber maintenance is very important if you've cut the TM at all. But if you've only performed a canaloplasty without cutting the TM at all, then there would not be a big concern for reflux hyphema because your incision in the TM is very tiny. So even if you destabilized your chamber a little bit, I would not expect an extreme amount of reflux hyphema in that case. So the other important thing to point out about the viscoelastic is that there's a pressure gradient between Schlemm's canal and the anterior chamber. So as you're doing the viscodilation and you're pumping visco into Schlemm's, you have to make sure that the pressure in the AC is at least equal to the pressure that's in Schlemm's. If it's much, much lower pressure in the AC and very high pressure in Schlemm's, this is when you can risk getting a Decime detachment. And so this is something you have to be aware of just to make sure that you're not overpressurizing Schlemm's with an underpressurized AC. So if your AC is, for whatever reason, the visco is falling out of your main wound or something, just refill it so that the AC is very taut and full under tension. This way, this will minimize any risk of Decime detachment. You also want to make sure that, you know, if the blinking light is not moving and your catheter and cannula are just stuck in one place and not moving, that you don't just keep dispensing viscoelastic, because then you're going to get many, many microliters of viscoelastic all in one location. And that can be dangerous for Decime detachment. So you definitely don't want to do that. Only viscodilate as the catheter is moving, either forward or backwards. And don't overdo it in one place. And make sure the AC is pressurized a lot. Otherwise, the pressure gradient will start to push things towards the AC too much, and you could end up with a problem with a Decime. Any other questions related to viscoelastic? I'll pause here before I move on to my next slide.
Mary, can I just look, you used the word tearing, and I know maybe, I don't know if that's the right time to ask this question or not, but I regularly try to tear it, and I can't tear it because it's too flimsy, the catheter. And I know that you showed that on that UK AGS. You showed it, but I've not been successful. I can only do 120, 180 with a lot of good luck. I mean, I don't think. So you're going to tell us more. I know that they used to use the old style catheter, right? That was with a micrograsp is different.
Yeah.
But with this new advance, as soon as you start to tear it or pull it, it starts to unwind. It comes out, but it doesn't tear. It's too flimsy to tear.
So thank you for bringing up the topic of tearing the TM with the catheter, which I'm sure you've all seen videos of this and presented at meetings, and it is officially not on label for that use in the UK. But yes, many surgeons are tearing the TM with this catheter, and I will show some examples then, since you brought it up, of ways to tear the TM either for 180 or 360. It is flimsy, but flimsy is good because it is soft. It is not rigid. It is not gonna, this catheter compared to Omni, it is much more soft and much less rigid. So it's not going to cause as much risk of a cyclodialysis cleft or iridodialysis or something. It's a nice soft catheter that will stay in Schlemm's, but the trick is how are you going to get it to tear TM if that's what you want to do. So since you've mentioned it, I do have some videos of that I will show, which are not on label for use in the UK. I've been instructed to repeat that every time I say that. Okay, I'm going to go to the next slide and talk about which patients do I choose for canaloplasty. And since you mentioned it, I will also mention which patients do I choose if I'm trying to tear the TM. So if I'm combining with phaco, anybody is a great candidate who has an open angle for straight canaloplasty. So if they have mild to moderate glaucoma under decent control with a couple drops and they need phaco anyway, 360 canaloplasty, great. It can get them off a drop or two. It can lower their pressure by a few points. There is very minimal hyphema risk. Even if they're on blood thinner, there would be very minimal hyphema risk. Even if they are monocular, there's very little hyphema risk. And so I would not hesitate to do canaloplasty combined with phaco without tearing any TM for literally anybody with mild, moderate glaucoma, or even perhaps well-controlled severe glaucoma, and you just want to do the most minimally invasive MIGS possible. So no implant, no TM cutting, minimal hyphema risk, very atraumatic, protected by episcleral venous pressure, no hypotony risk. So you're already going to the OR for phaco. So pretty much anybody can qualify. If you're going to be tearing a little bit too, this would be more of like a moderate to severe, or not as under good control, or more the secondary open angle glaucomas, like pseudoexfoliation, steroid response, pigment dispersion, the ones where the blockage is at the TM. I like to tear a little bit too. And you can tear 90 degrees, 180 degrees, or 360 degrees, depending on how aggressive you want to be about your tearing. And the beauty of the iTrack Advance is it's pretty versatile. You can tear as much or as little as you want, and I will show you some examples of how to tear more and how to tear less, depending on what you're going for. But I will not tear the TM if they very much, or 360, if they are monocular, or if they are on blood thinners, because that can cause a lot of hyphema. And if they're monocular or on blood thinners, I wouldn't want to do that. If I'm doing the standalone in a pseudophakic eye, this would be somebody who's not so well controlled on their current medical regimen, and they need just a couple more points of pressure lowering. If they have secondary open angle glaucoma, even if they're wildly out of control on their current medical regimen, if you tear the TM as well, you can sometimes see a dramatic pressure lowering. These are eyes that would normally have gotten a trab or tube, even pressures of 30, 40, 50. If the etiology is a secondary open angle glaucoma where the blockage is at the TM, then if you do canaloplasty and maybe add a little bit of TM cutting, you can often get dramatic normalization of pressure and avoid the trab or tube. And for standalone in a phakic eye, now I have a little bit more, got to think really carefully if you're going to go to the OR for a phakic eye. These work extremely well for the young people who have a juvenile open angle glaucoma where the problem is at the TM, or a young person with steroid response glaucoma, or like a uveitic glaucoma, and they're phakic and they don't have a cataract and you want to keep them that way. The canaloplasty part plus a little bit of TM tearing can often spare these eyes a trab or tube, at least for the short term, if not for a long time, because with JOAG, sometimes this can be curative if you can do something to the TM to restore the physiologic conventional outflow pathway. So again, this can be very titratable depending on if you just need a very mild response. You can just do canaloplasty, no tearing at all, pressurized viscodilation, 360 degrees or as far as you can reach. And then you can scale it up by tearing a little bit or a lot, depending on what you're trying to achieve. But again, that is not on label for use for that in the UK. Okay, I'm going to pause there before I start showing some surgical videos. Does anybody have any questions so far about the viscoelastic or which patients I would choose for this? Generally, they just have to have an open angle. Even if a little bit of PAS, I still do it as long as you can get the catheter into Schlemms. Especially if you can do a little bit of goniosynechiolisis, I still do it. If they have appositional angle closure, I still do it, because once the phaco is done and the lens is gone, their angle's open anyway. And under Helon 5, everyone's angle is open, unless they have like NVG synechial closure or like ice syndrome or something like that. Helon 5 will deepen anybody's angle. Okay, I'll stop talking.
Mary,
someone comment. Yeah.
Rajan has a question.
Yeah.
Mary, thanks. Do you tend to use it in uveatics?
Yes, I do. And so I've heard some conflicting philosophies on uveitic glaucoma and angle procedures at UCAGs and in the States too. I feel that there is one camp of glaucoma surgeons who swear by AMEDs for uveatics. And then there's a different camp of glaucoma surgeons, including us here at Cleveland Clinic at Cole, for uveitis, where the inflammation itself is quieted down by the steroid and they just still have high pressure, or steroid response that you get from the steroids to treat the uveitis. So now it's the TM blockage. Our sort of first line here at Cole is an angle procedure like goniotomy GAT. So in those cases, I would cut some TM and not just do the canaloplasty. But we are very big here on angle procedure for uveitis, and no implant, because you don't want to leave a metal implant for uveitis, but the TM cutting ones, we do that all the time. And my senior mentor here, John Isengart, who was my fellowship attending, he had his series of GAT for uveitic glaucoma and steroid response. They published that a couple years ago in Journal of Glaucoma, and one of our residents will be presenting the longer term outcomes of that at AGS coming up in DC in March. And so yes, if the angle is pretty open with not a lot of PAS and the etiology is uveitis and it's reasonably, inflammation is now kind of under control with whatever steroids are needed, we here will do an angle procedure with some TM cutting.
Brilliant, thank you.
And maybe it doesn't last forever, but if you can delay a tube in somebody by like even 5 years, I still think that that helps their eye in the long run. Of course, you want to keep a close eye on them and make sure that they don't PAS their whole angle shut, in which case they would get a sulcus tube or an anterior chamber tube. We like to do sulcus tubes here for pseudophakic eyes in terms of tubes. Okay, I'm going to move on to showing some videos. So this is a video of a 360-degree canaloplasty only with no TM cutting performed by my PGY4 resident. So in the United States, ophthalmology residency is it's intern year and then 3 years after that. So this is Jessie Wang. She's in her final year of her residency at the time of this video, and she is currently a glaucoma fellow at Duke Eye Center doing more glaucoma. So this is a canaloplasty by Jessie under my supervision. We're making a little otomy with a Sinski because I just wanted her not to have to worry about the otomy parts. But you can just do this with the injector. She's going in here with the injector through a para that's off to the side. She's using, this is the normal gonio prism that we use. I stain the TM with trypan, so you can see that it's blue. She's seating the cannula into that little hole that we made. You see the blinking light. You see there's no reflux bleeding. She's advancing the actuator. The catheter goes into Schlemms. It's coming around. You don't see the light too well because it's already zipped all the way around. Actually, it goes pretty fast. And now the light's all the way around and she's retracting. And so we're clicking to dispense viscoelastic on the way in and on the way out. We did about 20 on the way in, 20 on the way out. Her prism is sliding off a little bit. So I'm saying, keep it centered, keep it centered. And then she's accidentally cut a little bit of TM because she's moved her little cannula a little bit. So you see she created about a 1 or 2 clock hour goniotomy there, which is fine. And you notice that there was absolutely zero reflux bleeding. That's thanks to the Helon 5 that was in there. I'll pause here. Any comments or discussion about that video that I just showed?
Mary, is that angle open? That the one that is there an open angle?
Yes, that was an open angle, and we used trypan blue to stain the TM.
Yeah.
I do that too, just for cases combined with phaco to help my residents see the TM because sometimes it's very lightly pigmented.
Okay, did you say that you also use it in closed angles with Helon 5, right? You said.
Yeah, if the angle is appositionally closed without a ton of synechiae, then with Helon 5, it's open. Helon 5 is so heavy, it will push your lens all the way back down. And if there's a couple PAS, just a few focal PAS, I will still do it. If it's very broad PAS everywhere, I will not.
Rajan as well?
Mary, have you ever seen the catheter dip downwards and backwards?
Great question. Yes. So as you're advancing the actuator, you should keep your eyes on the blinking light. And so I tell my residents, look at the tip of your cannula and then look at where the light is, just with your eyes. Look at the catheter tip, look at the light, look at the cannula tip, look at the light, look at the cannula tip, look at the light, and follow with your eyes where the light is going. And so you should always be able to see the light. And if you don't see the light, that means that the catheter has dived posteriorly into the suprachoroidal space. If you're doing these cases under sedation with no block, the patient usually has discomfort or pain if the catheter were to dive posteriorly, and they'll go, ouch. But I actually do most of my procedures with a retrobulbar block, again, for my residents, so that they have an easy eye that's not moving, that's stained with trypan, with Helon 5, perfect setup. And so but the problem is they will not have pain. And so you cannot rely on the patient's pain to tell you that the catheter is diving posteriorly. So the beauty of the iTrack Advance is the lack of a blinking light tells you you are not in the right place, you are posterior. So you should immediately pull back on the actuator until you see the light again. And then you can try to continue to advance it, and sometimes it will then find the right place. Often if it's diving posterior, there's just a false track there for whatever reason, in which case you at least know that it's not going to go, and then you can remove it and then go the other direction. So make a new para and then go the backhand direction. It does dive posteriorly, less, I would say, than the Omni. The Omni is more rigid, so I feel like it just kind of finds its way to the wrong space a little bit more often. This one can also find its way to the wrong place, but at least you know it's in the wrong place, and you would not keep dispensing viscoelastic if you were in the wrong place, and you would not be like trying to cut the TM if the tip was in the wrong place. You would just withdraw it. So the light is a great safety feature to tell you if you're in the right or wrong place so that you can adjust accordingly.
Thank you.
Okay, I'm going to show the next video. So the next video, I was intending to do a 360 canaloplasty plus a 90-degree otomy using the iTrack Advance. But I was not successful in using the iTrack Advance to tear the TM because of what you said earlier. It ended up sliding out. And so instead, I did the goniotomy with the Sinski. But I want to show you why it slid out and what I've done subsequently to make it more successful. So here is the video. I hear some sound in the background, so I don't know if somebody needs to mute their microphone. I just hear a little bit of like a background noise. It's not a big deal. I'll just keep talking. Okay. So here we go. So this is the para. I actually don't make it that far over anymore. I've moved it a little bit closer to temporal. So this para is quite far over there. This is Helon, regular Helon in the AC. I'm using the tip of the injector to score the TM. You see it's pretty easy. Then I'm sitting there flush. Then I'm injecting the catheter in. You see it blinking. I double check that it's in the right place. You see the blinking light. I check that the blinking light is still visible on the edge of my view, and then it's going to fall off of the prism because it goes off to the side. You'll still see it blinking, though. You can see it here blinking, blinking. You see the blanching. The viscoelastic is getting dispensed. All the blood vessels are blanching, blanching, blanching. You see the blinking light. It's coming around. It's coming around. And now the blinking light is back in view. The blinking light is all the way around. And I have not moved my injector. And so now I was planning to only, I zoomed up so you can see all the blanching. So I changed my focus so you can see the blanching. And then I focused down again so you can see the nasal angle again. And so now I'm withdrawing the actuator and withdrawing the catheter. And this is my mistake. I withdrew the catheter too much. So now the blinking light is at 90 degrees. It's practically back in my view. So now I'm trying to cut the TM with it. It's so soft. It's not going to cut. It's so soft. It just falls out. So then I decided to use a Sinski to extend the goniotomy because I was intending to perform about a 90-degree goniotomy. So this is just a Sinski hook. It's free. And I'm just extending the goniotomy. And you see there's no reflux bleeding because I've already performed canaloplasty. So all the red blood cells have been pushed downstream. So the view is beautiful. It's white. There's no red anywhere. And then I just rinse out. Here you go, BSS on a cannula to rinse out your Helon. So the lesson here is if you are trying to cut some TM with this catheter and your goal is not to perform just a canaloplasty and you are intending to cut some of the TM, you have to not withdraw the catheter into the injector so much because you need to leave the catheter in Schlemms, anchored in Schlemms for more, and then the friction of the catheter in Schlemms for the whole circle is what anchors the tip of the catheter, and then when you start to pull, it will cut the TM. So I'll show you an example of that next. But before I move on, is there any other comments about this video? Okay, I will move on to the next one.
Well, Mary, we do have just one.
Oh, yeah.
Thanks, Mary. It was quite interesting how you show the what's it called, Sinski to go. Obviously, it's like a hook play, right?
Say it again. Sinski what?
It's like a hook play. You're using the Sinski to.
Yeah, I'm using the Sinski like a hook dual blade, except it's free. So I just had it on my tray. It's reusable, and yeah.
So one of the things, when I learned how to do Omni was that if you have too much of a slack in your catheter or it's a sixoproline, if you've got too much of a slack, then the otomy doesn't happen. And so you've got to be just about right for that slack. But on this, with the iTrack, what I also notice again is too much slack and I try to pull it. It doesn't pull. It comes out. It slips out.
Yes, exactly. You're right. So on Omni, they tell you that you have to like retract it as you trace the angle so that it's the right amount of tension, not too much slack. You have to be tight with the angle and trace it. And I don't like to trace the angle. I don't like to tell my residents to trace the angle. I don't want my residents to move in the angle like very big because I'm worried they're going to cause a problem moving around that much. And so the beauty of the iTrack Advance is that the catheter reaches 360 degrees. It is longer. So you have the benefit of the catheter being anchored in Schlemms for 360 degrees. And that anchor gives you so that you don't have to trace the angle. You don't have to retract and get rid of the slack. If you just keep more of it anchored and you just pull straight out, it will cut. And I will show you that video next. Okay, so this next video was done on Monday, this Monday, here at Cleveland Clinic. It is a monocular eye with a prior superior trab that had failed with pigment dispersion, pigmentary glaucoma, and he needed his cataract done. And I have a PGY2. So this is a junior resident. He has done like a couple goniotomies before, but he's just in his, PGY2 year of residency. He's extremely good. And we just did a iTrack wet lab for the residents last week. And so I said, you're going to get to try this one. And so this is a video of a PGY2 doing a canaloplasty and inferior 180 trabeculotomy. The reason the canaloplasty is only 270 degrees is because this is a left eye, and the left eye has a superior trab. So if we enter the TM at 9 o'clock and we go counterclockwise, then after 270 degrees, it will hit the trab site. And on gonio pre-op, the sclerotomy for the trab has like punched through where the TM is. So I knew the catheter was not going to pass the point of the trab. So I told my resident, we're going to only aim to go forward with the catheter 270 degrees, and we'll perform canaloplasty for as far as we can reach for 270 degrees. And then the reason we're trying to cut the TM for 180 degrees and not 360 is because I did not want a big hyphema for my monocular patient. And so if I want less bleeding, I just do the inferior half. And so that was the goal. And that is exactly what he did. And he did such a great job. And this video is literally from Monday. So I just edited it yesterday. Okay. And his name is Matt Henderson. And I hope he chooses glaucoma as a specialty. So here is the hands-free prism. Let me pause here. This is the Catena Corza hands-free prism. You just put it on the cornea and then you like squish down and it just kind of suctions onto it with a little bit of viscoat. And you can still use your finger to nudge it if you need it to like move a certain way, but it does stick on there on its own. And then I'm having my resident make a little cut on the TM before he gets started with the iTrack Advance. This is a Grieshaber ultra sharp dissection knife. It's a 0.5 millimeter blade. And I use, this is better than Sinskey because this is different than a Sinskey because it is more sharp. Sometimes with a Sinskey, it is so broad that I'm worried the resident's going to cause a cyclodialysis. And this is, for me, better than an MVR blade because the MVR blade is diamond shaped. So it's cutting on both sides of the diamond. So sometimes my resident has trouble getting it into the para because it's so sharp on the sides. They just keep getting stuck on the side of the para. But this one is only sharp at the tip and on one side. The other side is blunt. So it's like a kitchen knife. And so they can more easily slide into the para without getting stuck on the side of the para or accidentally making these false tracks on the para because it's not too sharp. It's only sharp at the tip. So Matt is taking this blade and just making a tiny otomy here on the TM to get started. And then he switches this blade to the iTrack. And it just goes right in. You see the blinking light. I'm clicking the visco. You see the blanching, 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 blanching. It looks so nice. He's not moving in the angle, blanching, blanching. The light is now stopped where the trab is. So I'm just going to rewind a tiny bit. And you can see, I paused it. You can see the red light where the trab is. It's on the bottom left corner of the screen. So like the light is practically in the bleb. So that now we're at 270 degrees. We've viscodilated the whole way, very dramatic blanching. All the red blood cells have been pushed downstream. I've clicked the catheter I've clicked it about 20 times up to this point. So now to perform an inferior TM cutting, which is not on label for use in the UK, I'm telling him, don't trace the angle, don't get rid of your slack. Just take your hand and pull this straight out of the eye. Do not retract the catheter. Do not scroll the actuator. Just take the whole thing, pull it straight back. So I'm going to press play and you can watch. He's pulling it straight out, pulling it straight out. You see that it's cutting, cutting, cutting. It's about 90 degrees, cutting, cutting, cutting. It's about 120 degrees, cutting, 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 180 degrees, and then it flips out at that point. So he has performed a 180 degree trabeculotomy with a 270 degree canaloplasty by just pulling straight out. No tracing, no slack, didn't move the actuator. Any question about that? And so the amount of traction that was on the catheter in Schlemm's was about 270 degrees of like traction. And that
there is a quick question, sorry.
Yeah, go ahead.
There is a quick question.
Mary,
Go ahead, Roger.
if you're doing a 180 degrees, do you tend to do it inferiorly?
I do. If I'm going to do 180 degrees, I do it inferiorly because hyphema and gravity. So I'm just hoping that it will bleed less and have less RBCs, less, blood. And so with this patient, when we saw him post-op day 1 on Tuesday morning, he had no blood in the AC, like 0. So the pressure was 12. His pre-op pressure was 15 on 4 med. And then I don't do any glaucoma drops the night of surgery. I just have them patched and shielded, no drops at all. Come back first thing in the morning for post-op day 1. And his pressure was 12 on 0 meds ever since surgery. And then I saw a chat question, why do I make the cut with something else? Is the tip not sharp enough? It is sharp enough. But to make the little slice with the actual injector tip, you have to go in and then turn it a little bit to make the slice. And this is like a PGY2. And so I just don't want him to like have to make this move in the eye. And so I just gave him a straight blade so he could just go like this and then go in with the iTrack and like not move. But it's sharp enough. You can just make it with the injector tip once you know how to move in the angle. But I just want to show that even like a MIGS baby, PGY2, can like learn how to do this. There's very minimal moving around inside the eye. Once you're seated there, and as long as the catheter finds its way to Schlemm's, if there's no obstructions and it doesn't dive posterior, which there's nothing you can do about that. If it's going to happen, it's just the patient anatomy. That's not your fault, and it's not anything the surgeon can do. But if there's no obstructions and it doesn't want to dive, it just zips right around. It's like super quick, and then you don't have to move your hand in the angle at all. You don't have to trace anything, and then you can achieve TM cutting just by pulling straight out. Okay, let me show you the next video, which is how do we do this if you want to cut for 360 degrees. There's a few different ways to do this, but here is one way. So as a recap, with the old iTrack 250A, you would use MST forceps or micrograspers or any kind of forceps, and you would take the catheter, which is not on a handpiece, and you would thread it all the way around in a circle, and then your microforceps would grab the other end as it comes around. You would hold on tight, and then when you pull one end and pull the other end, you would achieve a 360-degree trabeculotomy. But here with the iTrack Advance, your dominant hand is holding the handpiece, so you can't let go of it to hold the microforceps to reach with the other hand, and then your other hand is holding a gonioprism. And so there's a few problems with how you're going to retrieve the tip. You kind of need 3 hands. But here are some workaround strategies for how you can achieve that. Again, I'm making the otomy with a Sinskey, but you don't have to do that. Again, we're going in through a side para. The TM is stained with blue. You can see the catheter is blinking. It goes in Schlemm's. It's coming around. It's blinking. You're going to see dramatic blanching as the catheter comes around. Blanching, blanching. The light is blinking. Blanch, blanch, blanch. It's like bright white. All the red blood cells are gone. Blanching, blanching, blanching. The light has come all the way around now. So now I want to perform a 360-degree trabeculotomy. So I'm going to just zoom out. And I'm going to pull my injector out of the para, but the tip is still all the way around in a circle. I'm cutting this off the injector to free up my hand. And now I can use my right hand to go in and grab the tip and pull with both ends. So I had my assistant grab the tip with the needle driver so that I could stabilize it there. And then it freed up my right hand. I'm going to pause here for a second so we can discuss that. So by cutting the catheter off of the injector, you can then let go of the handpiece for a second. And then you can use your main hand, go in with forceps, grab the tip, and then you let go of the prism and grab the tail, like an old school GAT with the original iTrack. In this case, I did have an assistant, so I told my assistant to just grab the outside tip so it doesn't fall back in. But even if the outside tip that you cut falls back in the eye, that is still okay. You can take MST forceps and grab both ends inside the eye and then just pull it out of a para so it still works. The downside of cutting the catheter is the light doesn't blink anymore because you've cut the fiber that makes the light blink. So this can be tricky if you're working through an eye with a DSEC or an eye with a slightly cloudy cornea. If you were really relying on the blinking light to see the tip, you have to make sure you can visualize it without the blinking light if you truncate the catheter. That would be the only downside, but otherwise just cutting it frees up your hand. But I have a couple other strategies that I'll show too, but I'll pause for a second in case anybody has questions about this method of chopping the catheter off the injector, which is definitely not an official way to do this, but you know, works. Okay, I'll go on. Okay, so the next one here is very similar, but this eye has some PAS. And so I just want to show that you can do this in an eye with PAS. You just perform a little bit of gonius sneaculitis. Para to the side, myostat to constrict the pupil, Helon. I'm sweeping here to break up some PAS that's in that angle right there. I'm just using Helon to push some PAS down. There's some PAS over here. I'm using Helon to push it down out of the way. You see that just broke right there. Now I'm making a cut this time with that Grieshaber ultra sharp knife. Then I'm going in with the iTrack. It's going in Schlemm's. The light is coming around. We forgot to make it blink, so it's just a solid light this time. It's coming around, coming around, coming around. It's not blanching as much, but it's fine. We're still injecting viscoelastic. You see the tip there. It's not blinking because we forgot to make it blink, but it's still there. And then I'm retracting it out of the eye. I'm cutting it off the injector. It's no longer blinking, but I can see it. I'm grabbing it outside the eye. My assistant is, and then I'm going in the eye with forceps, grabbing the tip, and then I'm pulling with both ends. And that's it. So that was the same as the previous one, but this eye had PAS, and I was still able to perform 360 canaloplasty and 360-degree trabeculotomy with the iTrack Advance by cutting it off. Any questions here before I move on to the next scenario? Okay, I will move on to the next scenario. So this is an eye that has a prior eye stent, first generation, and it's a pseudophakic eye. And the pressure is like high teens on 4 meds, and they have a first generation eye stent in the nasal angle. And the goal here was to do a 360 canaloplasty and a 360 trabeculotomy, so full gap. And we were going to remove the eye stent. This is done by my PGY4 resident from University of Chicago, Ian Patterson. He is now a comprehensive ophthalmologist in Ohio, and he did 60 MIGS procedures with me as a resident. So he was very comfortable doing angle surgery by the end of his residency. So this is him operating. Para on the side, Helon, myostat, then Helon. Remove the eye stent with MST forceps. You see a little reflux heme because it's Helon, not Helon 5. iTrack, blinking light, or it's not blinking, but it's light. Goes in Schlemms. He was a little bit not centered here. I'm sorry, the video, it's a little off screen here, but it's going to come all the way around. You'll see the light come back when he makes it all the way around. Okay, the light is back. The light is right there. So now he's going to back out of the incision. He's going to take scissors, cut the catheter off. Now he's using his right hand to grab the tip. He lets go of the prism, pulls the tail to perform the full 360 GAT. And then BSS on a cannula to rinse out the Helon, keep the eye pressurized. That's it. So the 360 technique with cutting it off, so easy, a resident can do it. If you don't have, you know, a third hand. Okay, any questions about that before I move on to the next thing, which is a hands-free prism for the next one?
Can I ask you, did you notice that, or do you think the 360 outcome was superior to the 180? Because, as you know, it's quite a different technique, and also you've got to develop that reflex of cutting that catheter. It's a lot to do, really, and microcatheter and all that.
Yeah, that's a great question.
Different, better?
That's a great question. So when I was a fellow, I learned to do it as the full 360 with the original iTrack, and it was so satisfying to have it come all the way around, grab it. It's just so nice, and you know you got the whole thing. And then if it fails, then you know you did everything you could. You cut the whole thing. If it fails, okay, we're moving on to a tube. When I do 180, I'm just like, well, what if I had done the whole thing? Would it have worked? Sometimes it's just for my own psychology. Sometimes I want to do 360, but I get stuck and I can't get it, or they're monocular or whatever, and I just do 180, and it works great also. So sometimes I'm like, oh, maybe 360 is too much and 180 would have been enough.
It's very fulfilling to do. I entirely agree. Even with Omni, I try to do 360 most of the cases, although I can't really reason with why I do that. But with this, it's really, you know, cutting it out.
It makes you feel better that you tried. It just makes me feel better that I tried to do the whole thing. But if I can't get the whole thing and I can only do a portion, it often still works miraculously. So it makes me question if I'm overdoing it. I see another question with your hand raised. Go ahead.
Mary, just to be clear in my head, when you're doing 360, do you hold the tip with the MST and pull the end that you've cut?
Yeah. So when I'm doing the 360 and I've cut the end, then my dominant hand, my right hand, holds the MST and goes in through whatever para, grabs the inside tip, and then I let go of my prism. And then with my non-dominant hand, my left hand, outside the eye, I pull the tail. But if I have a resident, then I'll just tell my resident to pull the tail. But you don't need a resident. You can just use your other hand to pull the tail by letting go of the prism. Yeah.
Okay, so it's just it's just pulling the tail but fixing the tip basically with your MST.
Yeah, just fix the tip and pull the tail. You could also pull the tip and fix the tail. That would work too. Just pull either.
Okay, thank you.
Yeah. Yeah, I just got used to pulling the tail because when I did the old school way, where you passed it all the way around and you have your forceps and you grabbing the tip, my other hand was always ready with a tire to pull the tail. But I think some people, even doing the old iTrack, they just like pull with the main hand. It doesn't matter which one you pull, the same thing happens.
Thank you.
Yeah. Okay, so here's another video of the same resident, Ian Patterson, doing this whole thing with a hands-free prism. So not needing to cut the thing off, the injector, and you still get your blinking light. So he's going to make the little cut with that grease hopper blade. He's going to go in with the iTrack through the para on the side. Oh, here's the same hands-free prism I showed you before. Goes in with the iTrack with the para on the side, goes up to the little hole that he made, holds still, blinking catheter comes out, it's blinking, it's falling off the edge of where you can see with the prism, but you see it blinking around the edge, you see it blinking, it's coming around, it's at the left of the screen, it's at the bottom of the bottom left of the screen, it's at the bottom of the screen. It's not blanching that much, but I am viscodilating as he's going around. It's come all the way around now, 360. His left hand holds MST forceps, goes in another para, goes over or under himself. He's trying to go over, under. He's trying to decide which way to go. He goes under, grabs the tip, and then like Wolverine, he can go like, I feel like you're like Wolverine when you do this because both hands are kind of making an X shape. So he's holding still with the MST forceps and pulling out with the right hand holding the injector. But again, you can pull with either. And so this was awesome because this was my first time trying this with a hands-free prism, and I let my resident try it. So he got to do this before I got to do this, and he was very good. So I was like, I think you can do it. Let's try. I'll stop talking and see if anyone has any comments on this one. I guess no comments, but it's pretty cool that you just pop a hands-free prism on there and then your right hand just holds still, and then your left hand goes in with the MSTs and grabs it. And that's not that hard to grab with the MSTs with your left hand. Technically speaking, I think most people would be able to do that with no problem, even though it's their non-dominant hand. Okay, so next I'm going to show an example of where I just had to do it backhand because there was an obstruction. So I went forehand to try to do the full GAT, the 360, but it just would not pass. And so then I ended up doing it the other way around, and it worked. And so here it is. So now the iTrack is going in through a para on the other side. I'm holding this with my left hand, and I'm actually holding the prism, I think with my right hand at like an awkward angle, or maybe my resident's holding the prism for me. Sometimes I'll ask them to help me, or you can use a hands-free. And then it comes all the way around in the other direction. And now my right hand is holding MST forceps. I think my resident is holding my prism here. So my right hand's holding MST forceps. My resident is holding the prism. Then you make that X-Man Wolverine move and pull with both ends or pull with one end and do the whole GAT. In a way, it was almost more comfortable this way because my right hand was holding the MST, which is the way that I would have done an old school GAT. Okay, any questions on that one? Almost done. Last video here. Or yeah, one more. So this one is a 360, but I hit an obstruction both ways. So I couldn't get the whole 360 all in one go. I ended up having to do one half and then the other half. So this is my resident Jessie. She was a PGY4 for this case, and she is starting the case. The goal here was just to do 360. So she made an otomy with her Sinski. She goes in with the iTrack through the para on the side. She seats it into Schlemm's. It's Helon 5, I think, in the AC. She's holding still. She's advancing it forward. The light is blinking. It's going around. It's going around. It's coming around. And now it's going to stop right there. So it's at the bottom right corner of the screen. You see it's blanching a little bit right in that position. Blanching. She's buckling because she's trying to push it forward and it's not going. So the catheter is almost buckling. And I'm like, stop pushing. Back it out. Let's try to back it out. Let's inject more viscoelastic and push through the obstruction. And then push the actuator forward, but it's not going. And she just keeps getting stuck. So I told her to pull it back out. So she pulls it back out. And then I think either I said try again or I did it. I think I switched places with her and then I tried. So this is probably me trying the same thing. So push it forward, viscodilate a little. It gets stuck in the exact same place. So this is probably a hole for the collector channel, like an orifice of collector channel that is just stuck at an acute angle. I can't get past it either. So I'm like, okay, it wasn't you, it was just anatomy. So we flipped it around. We go through another para a couple millimeters away. and then we go the other direction. It comes around, and it actually passes that area that was blocked before, but then it gets stuck in a different place. Now it's getting stuck in the bottom left of the screen. And I was like, ugh, I'll just take what I can. So I pull it straight out and I get about 180, you see? And then I come out and I'm like, let's do the first side again. So then I go back around the first side, I get stuck in the same place, and then I just try to pull what I can, get what I can. It's a little flimsy, as you say, so it's not cutting the whole 180, it's cut about 90 right here, and then it starts to retract out. So I got about 270 to 300, even though I hit an obstruction in a different place in the two directions. So this just goes to show that sometimes the obstruction is not within Schlemms, it's just you're hitting the opening of the collector channel, so no matter what, you're not going to get past it. But if you're passing it the other way, the hole is not pointing into it, it's going the other way, so you can get past it. So don't hesitate to try the other direction if you hit an obstruction one way, and sometimes you'll be able to get the whole 360 the other way, and sometimes you can only get a portion of it in each way, which is still fine. Just do what you can on both directions. Okay, any questions about that one? And that's the end of my videos. So then I'm just going to show some slides about outcomes, and then that'll be the end. Okay, so no questions about that technique or anything. So what are the outcomes? So this is a poster that's going to be getting presented at AGS. This is data from the iTrack Global Data Registry, and this registry is in collaboration with the International Glaucoma Surgery Registry, which was founded by Keith Barton. And
sorry to
okay, I'll stop talking. Hey.
I struggled to unmute in time. There was a quick question from David up in Middlesbrough.
Okay, go ahead, Dave.
Hi, yeah, sorry to interrupt you and
no, go ahead.
It was just sort of coming back to the how much do you cut kind of thing. I just couldn't quite get my head around what you were suggesting there. I'm thinking, well, you mentioned you could do 90, 180 or 360, and are there times when you think I'm really worried here, so I want to cut a bit but can't quite bring yourself to do even as much as 180, and other cases where you do 180, have a good result, and then at some other time would ever go back and would do another 180, or in your mind have they then moved on to the next thing, whether that be trab or tube or whatever? I'm not quite sure I've clearly asked that question, but
okay, that's a good question. So usually if I'm trying to go big, I just do the 360. If I'm going small for cutting, it's usually because they're monocular or on blood thinners. Like, to be frank, that's usually why. Because if I want to go really, really small, then I just won't cut at all. I'll just do the canaloplasty. Like if they're just mild, like literally mild to moderate on one drop, and I just need to do the phaco, I just won't cut anything, because why bother with any hyphema? So if I'm cutting at all, I'm trying to cut big. So I'm trying to do 360 for everybody. But if they are monocular or on blood thinner or unreliable as a patient, or just can't keep their head elevated or whatever, then I'll cut in the middle. So 90 to 180, in which case I'll just get approximately 90 to 180, like whatever I can get when I just pull the thing straight out. And then if it works for a while and then wears off, I suppose I could do the other 180, but the reason I didn't do 360 in the first place was because they were monocular or on blood thinners. So in that case, I would just move on. But if the reason you did half was because you wanted to just treat a little bit and you just didn't want to commit to the whole 360, but they're not monocular or on blood thinners, then you totally can do the other half later.
Okay. And we have another question from Tanya, and then Roger.
Yeah. Hi, Mary. Just a question about canaloplasty only and your successes. So before we move to the registry data, which are canaloplasty only, is there something that you would like to add on the percentage you do on canaloplasty only and your success cases?
Yeah, canaloplasty only works really great for patients who are good candidates for canaloplasty only. So, I mean, don't do it for uncontrolled severe stage POAG. Like, that will probably not work for canaloplasty only. But if you're choosing canaloplasty only for mild to moderate POAG on 1 to 2 drops at the time of phaco, or 1 to 2 drops but intolerant to the drops, or like slightly out of control but you just need a little bit of a result, then canaloplasty only works great. So people who are like 18 on 1 to 2 meds with like a nasal step and you're doing phaco, you can get them off their 1 med and their pressure will end up like 15 or 14 or 13 or something, and that is a success for what you want them to have. So for example, since I started my new job here, there was a lady who was from Albania and she didn't speak English. She was here with her daughter. She came on betaxolol and she had just one drop on board. It was prescribed by her doctor in Europe. And wait, is Albania in the EU? Well, you know what I mean. Overseas. Is Albania in the EU? I'm sorry. That is Europe, right? Okay, never mind. She's from Albania though.
Yes, it is.
Yes,
it is.
It is, right? Okay, sorry, thank you. So she was on betaxolol. Her pressure was like high teens. Her OCT was like very mild thinning, and her field was full. And so she just needed phaco. So I was like, great, I'm going to add canaloplasty only. No need to cut anything. I'm pretty confident I will get you off the betaxolol. And, you know, maybe phaco alone would have done it too, but why do phaco alone when you can add a little flush of the natural drain without causing any other problems? So I added the canaloplasty. I feel like it's like so easy to add, no harm at all. So she got it done. Now she's like 12 on no meds. And it's hard to, I mean, I don't have head-to-head data for phacocanaloplasty versus phaco alone in a randomized fashion. I don't have that result, you know, but I feel like if you add canaloplasty only, you're increasing the chances that the patient will get off their one drop and or lower their pressure by a couple points for somebody who is, you know, otherwise not extremely severe, under reasonably well control. Get them from high teens to low teens, get them from 2 meds to 1 med, you know, something like that. And so I've been offering canaloplasty only for situations like that, where I just need a little bit of something and I don't want to cut TM, cause a hyphema, or leave an implant. Because why? Why do that when you don't have to? I see another hand raised.
Thanks for that question, Tanya. Yeah, that's Roger.
Mary, do you cut the TM for patients who are on blood thinners?
So I used to not cut the TM if they were on blood thinner and could not stop it. So if they're on blood thinners and can stop it for a few days, then I will treat them like normal, and I will even do 360. If they can stop blood thinner for like a week or even 3 days. If they cannot stop it, I used to do like no cutting at all. And then I kind of eased up a little bit because there's some patients who are like pseudo exfoliation and they're on blood thinners, but like I know this would work so well. And so then just recently I've started cutting, but less. So definitely inferior, and I'll do like 90 degrees or 180 degrees if they're on blood thinner. And then just make sure you keep the eye pressurized and don't make them do any glaucoma drops the night of surgery. And on post-op day 1, if their pressure is not sky high, don't resume any glaucoma drops and just keep the pressure in the eye on the high side. That way everything will flow downstream. I think sometimes people make the mistake of resuming too many glaucoma drops and there's a hyphema, but if you put too many glaucoma drops on board, the pressure is so low, the hyphema won't clear. And so something I'll do is just like let the pressure rise so the hyphema for sure clears, and then put the glaucoma drops back. I mean, don't let them spike and don't let them snuff out or anything, but err towards keeping the pressure on the high side to make sure the blood clears out. So nowadays I will do 90 or even 180 inferiorly if they're on blood thinner, if I really think it's going to work. If it's like a secondary open angle glaucoma and I'm pretty sure this is going to work and spare them a tube, I'll go for it. But I'll counsel them about the hyphema risk and everything.
Brilliant.
Great question, Rajan. One more question and then we'll move on. This is
Okay.
Aisha from Lancashire.
Okay, I just want to make a comment, Mary. So for hyphema, which as you've alluded to is very common, I often give patients transdynamic acid, 500 milligrams, and you can give it up to TDS. I have once had to give IV because I was very worried about intraoperative bleed. For I think patients who, other than patients who are on who have mechanical heart valve, IE and then warfarin, I try to reduce the INR maybe, so I can't stop the warfarin, but also reduce the warfarin so that I can get an INR with maybe no more than 2.5. But even then, there's a risk of intraoperative bleed. So definitely use, and also you can use transdynamic acid IV, or you could give oral. And the other tip also is that you tell the patient to lie on the side of the eye that you have operated upon, which will help to prevent too much bleed. And last is, as you've alluded to, that you have to, if the eye is too soft, then it will bleed more. And therefore you have to really make sure that you've left a firm globe at the end. We just want to share that. Thank you.
And then I just tell them post-op, no bending, no lifting, no straining. Don't bend over to tie your shoes. Don't bend over to pick up anything on the ground. Don't lift more than 2 pounds. Just sit on the couch, watch Netflix. Tell me next week what you've binge watched. Don't do any chores. Don't bend over to feed your dog. Don't bend over to feed your cat. And I just tell them to sit on the couch. And then by 1 week, the blood is for sure gone. I actually had a very weird hyphema recently, so I'll just share the story for 1 minute and then I'll move on. I tell the patients who are getting a 360 that the hyphema rate on day 1 is pretty high. You're going to have some blood. By week 1, like 90% of the time it's gone. And by month 1, like 99% of the time it's gone. And I had this one lady who had uveitic glaucoma and steroid response, who had a totally open angle pre-op. I did a GAT. She was pseudophakic, and her blood was still there by month 1. And I was like, well, I'll see you in another month. I swear it'll be gone by then. And it wasn't gone. It was so weird. And I go near her, and she had some new inferior PAS. And so I was thinking she formed some new inflammation post-op. And because she had inflammation and PAS in her inferior angle, with the gravity, the blood was not draining. And I was like, well, let's just give it another month. And then I saw her at post-op week 14, and there was still a tiny bit of blood, and it was swirling around. It was blurry, and I was like, what the heck? And she did not want an AC washout. She just like didn't want to go back to the OR, and she didn't want to bleed more. So I was like, what am I going to do? And I often will give pilocarpine to help a hyphema clear post-op. In fact, actually, after most of my TM cutting MIGs, I will give pilocarpine twice a day for 1 week. But because she's uveitic, I don't like to give the uveitics pilocarpine in case it is pro-inflammatory. So I didn't want to give her pilo. So I had this crazy idea to give her TPA, like Alteplase, because I know you can give it for fibrin, to bust up fibrinous clots that are blocking your tube. She didn't really have fibrin. It was truly liquid blood. So I don't know. I don't know what I was thinking, but I was like, well, it's blood. Maybe I can bust up the blood. Maybe this will somehow help. I don't know. She doesn't want to wash out, and she's been like this for 14 weeks. So she agreed. So I ordered TPA from the pharmacy. They delivered it to clinic. I gave her intracameral TPA. And when I injected it into the eye, the blood was liquid. So it like swirled around, like just the liquid, the stream of fluid going into the eye, like swirled everything. And then I was like, okay, let's see what happens. And in 1 week it was gone. So I don't know that the TPA necessarily like did anything to her red blood cells. I wonder if it just like helped everything move, and then it left from the angle nasally or temporally or something. So I was thinking maybe I should have had her lay on her right side or her left side. I couldn't have her do a headstand for a week. So the TPA just kind of swirled thing, so it wasn't just resting in the inferior angle on top of the PAS. And I had one other hyphema that would not clear, and she had inferior PAS afterwards. So I think sometimes if you have too much post-op inflammation where you get new PAS inferiorly, because that's where PAS will grow, it might slow the hyphema clearance. So if you have a hyphema that's not clearing, it could be PAS as a problem. That's just like a side note. Okay.
Thank you so much. Excellent point. Thank you. I've read that loads of hyphemas, there's a subset of patients, you can't predict who they're going to be, but it takes forever to clear. Sorry, one thing about the TPA is that it can cause the lens to go cloudy. So that has kept me from using it, because I don't want to be from, unfortunately, from having a hyphema now to a cloudy lens. I don't know what the incidence of that is, but it can cause the IOL to become opacified. That's my.
Oh, interesting. I didn't know that. I've only used it like 3 times, like ever. It's usually for a fibrinous clot that's blocking a tube. But usually, but she just was refusing to do anything else, but she was unhappy. So I was like, I don't know what else to do. Yeah.
It's very difficult.
Okay. So so this is from this database that Keith Barton and
Mary. Oh yeah. Mary, sorry to interrupt. So just to make a comment, the results you're going to present now is canaloplasty only. So
this is canaloplasty only, no TM.
Because I love the GAT stories and the bloody things, but
these excellent results that I'm about to show are just for 360. I think usually 360 degree, but definitely canaloplasty only, no TM cutting. Yes. And so this is like people will just put their cases into the registry. It's multi center, so there's 63 countries, 7,000 procedures of various types of glaucoma procedures in this registry of all types of glaucoma surgery. And this is an analysis of all the cases of primary and secondary open angle glaucoma using iTrack or iTrack Advanced canaloplasty only. And so these are the data separated as combined with phaco on the one side and standalone on the other side. For standalone, it can be in a phakic eye or a pseudophakic eye. And then combined with phaco, of course, they had a visually significant cataract. So for the IOP, you can see the baseline IOP in the high teens, and then you can see the IOP in the month 12 and month 18 and month 24 is in the low teens. So for both standalone and for combined with phaco, you're starting in the high teens or even 20 for the standalone. And then by year number 1 and year number 2, you're pretty much ending up in the low teens. And then for meds, you're starting off like more than 2 meds. And then by year 1 or year 2, you're at like 1.5 meds. So it works pretty well for lowering the pressure by a couple points and getting off like a drop or 2 with canaloplasty only, with or without phaco. And so both of these were significant at year 1 and year 2 for both the pressure and the med reduction. I mean, it's not surprising that the baseline pressure is higher in the standalone group, because for the combined with phaco group, usually you're going to the OR because you have cataract, whereas for the standalone group, you're going to the OR because you have a pressure problem and you need to solve the pressure problem. It's not just for med reduction usually. So that's why the pressure is probably higher. And then here's the success rate. So complete success was defined as pressure reduction greater than 20%, no increase in meds, or final pressure under 18 with no meds. And then qualified success was final pressure less than 18 with less meds than before. And then a failure would be pressure reduction less than 20% or increase in meds or need for additional surgery or loss of light perception or hypotony on 2 consecutive visits. And so you can see the complete success rate for the combined group is 62% and the complete success rate for the standalone group is 54%. And the success rate is slightly higher in the group with combined phaco because we know that phaco lowers pressure too. So of course you have that little bit of extra oomph from the phaco part, but even in the standalone group, you can see that a lot of the success comes from the canaloplasty itself because the standalone group, there's no phaco involved. And so that's pretty great for a procedure that only enhances the physiologic outflow pathway, does not have hypotony risks really, does not have a bleb, does not have an implant, does not have like hyphema, because this is canaloplasty only, no TM cutting. And then this graph here is for the medications, and it's just showing medication reduction. So it's just showing how many people were on 0, 1, 2, 3, or 4 or 5 meds before, and then how many eyes were on 0, 1, 2, 3, 4, or 5 meds after. So you'll notice that a lot of eyes ended up on 0 meds after. A lot of eyes had a couple meds before, and many of them shifted towards being off meds. So you can do canaloplasty only just for medication reduction, as opposed to pressure lowering, if that is the goal. Many patients have preservative allergies or just bromonidine allergy or whatever. And so canaloplasty only is a very non-invasive, minimally invasive way to do medication reduction. These are just some pictures of me and my residents from University of Chicago doing iTrack Advance. I'm starting to take some new pictures with my Cleveland Clinic residents as well. And then we'll be sure to email you all my contact information, but this is my Gmail. And I have a YouTube channel with surgical videos. I uploaded some iTrack videos, and I have a lot of tube and tube revision videos as well. And please follow me on Instagram, Mary Qiu MD. It just has usually pictures of my residents doing surgery or papers that I've published or my travel pictures or food or my dog. Okay, that's it for my official presentation, but we can keep chatting.
Thank you so much, Mary.
Yeah, I was just undoing my microphone, saying thank you so much, Mary. That's been absolutely wonderful, very insightful. Those videos are absolutely brilliant. Thank you.
Mary, just a quick a quick summary from me. It's Kevin Pitt here. I've just got 2 actions for you: to send the link to the gonio prism that you use, and to share the link for the off-license, stress off-license in the UK, tearing out of the trabecular meshwork. That's the 2 actions I've got for you.
Okay,
Lovely.
Will do.
Thanks,
okay,
Mary.
I see another question with the hand raised.
Mary, are you able to share your results with trabeculectomy? Trabeculotomy. Visco and...
Yeah, like with GAT, like with the full GAT. Yeah. So we published our paper from University of Chicago of all of my resident performed GAT. So you can find that on PubMed, but it's like resident performed GAT with iTrack. And so these are just all the PGY 3s and 4s performing GAT with the old school iTrack, not even with the iTrack Advance. And I don't have it off the top of my head right now, but basically the pre-op pressures, usually these are eyes with secondary open-angle glaucomas. So pseudo-X, pigmentary, steroid response. Those are my 3 big secondary open-angle glaucomas that I do this the most for. And usually these are eyes with pre-op pressures that are like 20, 25, even pushing 30. And for the secondary open angle glaucomas where the blockage is entirely at the TM, I will often end up with pressures in the mid-teens on like practically no meds, especially for the steroid response ones that are like Ozurdex, Iluvien, or like chronic topical pred in the setting of a DSEC or a DMEC. They can be like 25 on max meds and Diamox. And as long as their angle is open enough and you can see it well enough, if you do the full GAT with the trabeculotomy, I mean, I do 360, but you can probably do less. Often it normalizes the pressure, like literally fixes them. Like I had a medical student from University of Chicago. He had VZV, uveitis. He was on pred, and he was at like 30 something on max meds and Diamox. He was phakic. I did him under general anesthesia and I with Helon 5 because I was so nervous. And he ended up at 11 on Timolol. And it just when the blockage is purely at the TM, doing the TM cutting fixes it. And I feel like in those types of diagnoses, canaloplasty only will not necessarily achieve the same result because you really have to cut through some of the TM blockage. But when it's like a mild to moderate POAG situation, then canaloplasty only can give you the result you want, but like a more modest result. But you can achieve really dramatic, like tube-like results with cutting TM when it is secondary open angle glaucoma. The results are not as good for the full GAT when it's POAG. Because if it's truly POAG, then the blockage is also downstream in the collector channels and stuff. So if they were like 35 on max meds, I would not expect a GAT to be able to lower them to, 12 on no meds. I did have an example, African-American lady. She was like 85 years old. She was pseudophakic. Her baseline pressure was 28 and 25 on 4 meds, and she was pseudophakic. And she was just so elderly. And I did a GAT in both eyes because I was hoping to avoid a tube. And it got her down to like 21 and 18, like from 28 and 21, but that was still too high for her. So I ended up doing tubes anyway. So it's like, for example, with POAG, you can get them lower, but it might not be as low as your target. But for secondary open angle glaucoma, it is a literally miracle. So currently my fellow is working on publishing our results from Cleveland Clinic of the pseudoexfoliation glaucoma with GAT because we have long outcomes here because my mentor has been doing iTrack since 2015. So we should have 9-year outcomes from his earliest cases here. And same with steroid response and same with pigmentary. I have a resident working on publishing our pigmentary series. And then our updated paper for steroid response is going to be submitted for publication soon. So my goal is to just make sure we put out all the data for canaloplasty only and also for GAT because it works better than you would think, almost tube-like for secondary open angle glaucoma. So that's actually one of my big takeaways about GAT. And then canaloplasty only is like awesome for your slightly more mild to moderate cases that are not wildly out of control and is just so non-invasive compared to KDB or iStent or Hydrus or anything where you're really tearing a lot or leaving an implant. Especially when teaching trainees, the implants can often end up in the wrong place. So I have found teaching trainees to use iTrack Advanced to be very easy and safe because of the light. You won't get them into trouble because you'll see where they are. And you're just not leaving anything behind. So you can't leave something in the wrong place.
Thank you.
Yeah. Hopefully I'll have another chance to visit the UK sometime soon. If ever you guys would like me to give a talk for your colleagues at your institution or something like that, please let me know. My other interest besides GAT, I also sort of like neovascular glaucoma, which I talked about at UKEGS. I also do a lot of fun stuff with tubes and tube revision. So if you want to hear about that, I can talk about that. And I'm also really into surgical education for trainees. So I have a lot to say about how to teach residents, MIGs, and tubes and stuff. So that's me.
Another question
so
from
hopefully
David,
we
Mary,
can. Yeah. Hi, David.
Hi. Sorry to keep pestering you with questions. I may have missed it earlier on, but do you have sort of a standard post-op regime in terms of timing,
yes,
how aggressively to take the meds off and stuff? Because I'm sort of relatively experienced with Hydrus, and I always want to push it, and I'm lucky that I've got day one clinic available to me after I operate sort of the evening before, so I just stop everything. And obviously sometimes that's not the right thing to necessarily have done, and you sort of relatively quickly adding stuff back in. But do you have a sort of particular amount of steroid you give people? Do you have
great
a
question.
particular, all of that? Thanks.
So steroid wise, for normal phaco, I do pred acetate 4, 3, 2, 1 stop. And then in my Chicago job, I had more African American patients and they had more inflammation. So I was sometimes doing 4, 4, 3, 3, 2, 2, 2, 1, 1 stop, or like 4, 4, 3, 2, 1 stop. I was doing ketorolac just for everybody in Chicago because everybody was a little bit more pro-inflammatory. So I would add it on for this too, just out of being extra. You don't need it. Sometimes you can use ketorolac instead of pred if you're trying to avoid a steroid response type of situation. So now standard GAT in my Cleveland population, I will do 4 times a day for 2 weeks, then 3, 2, 1, stop. If they have a ton of blood on post-op day 1, then I will do pred every 2 hours for the first week and then cut down to 4, 4, 3, 2, 1, stop. I will always do pilocarpine 1% twice a day for at least the first week, unless they are high myope or have uveitis, in which case I will withhold the pilo. On post-op week 1, I will gonio them, and if they have no hyphema, I'll stop the pilo. If they have a tiny hyphema, I'll continue the pilo till the next visit. I think the pilo helps the blood clear. As far as glaucoma drops, if I'm doing a GAT, like a full 360 cutting GAT, I will stop all the baseline drops because I want the pressure to rise so the blood goes away. If I'm doing canaloplasty only and my goal was to get them off 1 drop or 2, then I will stop the drop because that was my goal, just to get them off 1 drop or 2. If I'm doing canaloplasty only and the goal was pressure lowering, then I will continue all the baseline drops because my goal was to lower their pressure, not reduce the drops. So depending on if my goal is med reduction or pressure reduction, I will either stop the meds or continue all the meds if it's canaloplasty only. But for GAT, I will stop all the meds because I want the pressure to rise, to push the blood downstream. And then antibiotic plus minus. We do intracameral here. So a lot of the doctors here don't do topical antibiotic, but I do it anyway just because I'm nervous. Ketorolac, same thing. Most people don't do any NSAID, but I sometimes do it anyway because I'm nervous. And then, if it's a uveitis glaucoma patient with a history of CME, like cystoid macular edema, do you guys call it CMO? Because edema is spelled with an O, but cystoid macular edema. Sometimes we'll actually give intravitreal triamcinolone or Kenalog if I'm doing a full 360 GAT, just to help reduce the risk of PAS and macular edema, because the GAT will really prevent them from having such a high steroid response. So oftentimes when the case is a uveitis patient, we'll do GAT plus intravitreal triamcinolone. Or I've seen my mentor will do they'll do Retisert combined with GAT, or like a big heavy duty steroid, and then we'll combine with GAT. For uveitis.
Thank you. That's a super comprehensive answer, and thanks for the talk. Really interesting. Thank you.
Yeah, thank you all. Oh, another question. Yeah.
Mary, regarding the post-op steroids, do you prefer Pred Forte to dexamethasone or Maxidex?
We just use Pred Forte for everything in the States. So like just for cataract surgery, the most common steroid that we would be using is Pred Forte, Pred Acetate. So that is just kind of like the standard one. Sometimes if they're having a steroid response, I will switch to fluorometholone. And then if they are a uveitic at baseline, sometimes I will use Durezol or difluprednate instead. So those are pretty much my 3, like medium, big, or small steroid. Pred, and then Durezol, and then fluorometholone if I want to go bigger or go smaller on steroid. We just don't use that much dexamethasone in the States. Like, I don't know why, just nobody really goes to that one.
Thank you.
This has been so fun. I hope you guys thought this was interesting. I'm really glad I got to share all of my videos with you guys and have a full 90 minutes to talk about everything, because I met some of you guys at UKEGS and it was just really quick. And I was like, oh, let me show you this cool video. But I had all these extra videos. So I'm really glad that we had a chance to just talk about it all together in a small group so that we could all kind of chime in and it wasn't just bajillion people and anonymous faces. So I thought this was really fun. Hopefully I'm going to plan to come to ESCRS, so maybe I'll see some of you guys there. And if there's ever anything you would like me to do in the UK, just let me know. I'm always up for sharing my experience with glaucoma surgeries, MIGS, tubes, whatever else. Yeah.
Thanks, Mary. Great presentation.
Thanks so much again, Mary. It's been wonderful listening to you.
Thank you. Thank you. I'll stay on the call for a few extra minutes so I can touch base with the Haag-Streit people. But if the audience wants to sign off, I think that would be reasonable. Yeah, thank you all for spending your evening with me.